It's time to enhance the relationship between expertise and impact, between knowledge and application. Welcome to a journey of discovery and empowerment. Welcome to All Physicians Lead, the Forbes Books podcast that highlights the critical leadership role that all practicing physicians take on every day. Here's Dr. Leon Morse.
My guest today is Dr. Maria Granzotti, a seasoned physician executive with over 15 years healthcare leadership and 20 years in emergency medicine. She's driven quality, safety, and transformation across healthcare systems, serving as a chief medical officer at Ascension and Whole Health Living. Currently, she's a CMO and clinical strategist at Church Streeter and Cross. Dr. Granzotti, welcome to the show.
Well, thanks for having me, Leon. I appreciate it.
Well, it's very exciting. I've read a bit of what you've been working on over the last decade or so, and looking forward to talking about that. But before we get started, it's always great for the listeners who may not know you to hear a little bit about your background. Tell us how you got started, what got you interested in medicine and leadership.
Well, it's a long history, I will say, but my grandmother originally, she was an Iowa farm wife, and she was an RN for over 50 years. So I would spend the summers on the farm. Growing up in Texas, I would go up to Iowa with my sister, who was also a physician. And her example of just plain stubbornness and grit and flexibility and resiliency, I think really set the stage. So I practiced after attending University of Notre Dame for undergrad. I was a science pre-professional. Back then, it was a typical, pre-med, but it was a very nice, very focused way to get into medicine. And I knew since I was very, very young that I wanted to be a physician in healthcare, very, very young. My mom has a picture of my sister and I with the old doctor's play kit with the red, I'm going to date myself, with the red plastic doctor's kit.
I'm very familiar, yes.
Yes, and I was very angry. The picture is very demonstrative because I know that it's a fake kit. I know it's a fake kit. So anyway, after Notre Dame, went to University of Texas Southwestern Medical School. And then I did my internal medicine residency at Rush Press, but then actually ended up practicing emergency medicine full-time for over 20 years. After that, I knew there was much more to do. I really wanted to focus and grow in the quality and safety space. So I became chief medical officer. My first role was in 2009, and organizationally, number of organizations that I led in that role grew and grew until my last year. That my last largest roles was Ascension in Texas. I was their chief medical officer for Ascension, Texas. There were 14, 15 hospitals at the time. My husband unfortunately passed away suddenly in 2020. So I needed to take some time off and really focus on what I wanted to do and what I wanted to continuously learn. So I got into the payer space for a bit as a chief medical officer for a national company. And then as of January this year, I decided, you know what? I really want to put my shingle out there as an advisor or consultant. So I'm dabbling in different spaces now and continually learning every day.
Well, that's neat. That definitely keeps us young, right? Always learning new things. And
yes.
I respect that, appreciate that. We'll get to talk about that here today. So thanks for joining us again. Along that pathway, if I remember correctly, studied and received your MBA.
Yes,
tell us a little bit about that. What was that decision like, and how has that educational experience shaped your journey as well?
Yeah, that was my first CMO role, and I remember my CNO at the time coming to me. I had been in the role about 4 or 5 months, and I was very blessed in that they had never had a full-time CMO at this organization. It was about 250 beds at the time, 300-bed community hospital, very competitive market. And she came to me and said, "Okay, what's next?" And I was like, "Well, what do you mean? We're addressing these factors, and whether it's medical staff, whether it's quality, whether it's accreditation, risk, compliance, you name it." And she's like, "No, you." She was a true mentor. She's like, "No, what are you going to do?" I said, "I've always wanted to understand more the business side of medicine, and I've never gotten to do that, the opportunity in the training." So I actually obtained my MBA. After having received my chief physician executive certification through the American Association of Physician Leadership, which is a great organization. And
very familiar.
Yeah, that work was able to be applied to different MBA program access. So I got mine through UMass Amherst. University of Massachusetts Amherst, which was great. It just gave me a whole new perspective and another side to be able to work from in the medical field.
So throughout those transitions, you described a little bit about why you went into some leadership roles, really like we all probably do, the reason we want to make a difference at a different level, a different job. When you're doing those transitions, were you aware of a pathway that was specific in front of you and you were building this to go into that? Or were you more like me, for instance, where something opens up and you say, oh, that looks like fun, I might try that leadership role? How did that play out?
Yeah, it's very interesting because, the CMO role, that was just when the CMI role pieces were also coming. But back in the day, this was 2009, 2010, the majority of CMO roles really had to take that into account. So I was neck deep into meaningful use, interoperability. So I really got a lot of exposure to that technical side. So it was really nice. I had the business side also. I always thought, it's one thing, and I'm not going to discount it all. It's a sacred space to impact individual patients at a time. But I had a larger vision of I would really like to impact on a larger scale and not just the patients, but also, I'm saying just the patients facetiously, but just the patients, but also the caregivers and the entities in that delivery that much more. I didn't have in my head, I want to be a XYZ. In fact, as the years have gone on, I got more away from the titles of roles, more to what am I responsible for and where can I really make a change? Where I've always been one to interconnect the dots. I'm a dot connector and how something, I know where we need to be and how those dots connect in order to get there. Those railroad tracks to get there is what really drove me.
That's nice. And again, making a difference for patients at a different level. Obviously, all those folks that you talked about, the team members, physicians, other clinicians, clearly impact those patients on a day-to-day basis. So congratulations, kudos on that. When you started down that pathway, something that I think many of us face, how did you balance your clinical work? Because there's a tail there with transitioning into leadership. How did that decant off? How did that balance occur for you over years and years?
Yeah, I mean, I had always been engaged, whether, I had been EMS director in one of my first ER emergency attending roles. I had also been a teaching attending in the ER when I was at Rush Presbyterian right after residency. So, what was interesting is that the first 2 to 3 years in that first CMO role, I continued to work clinically, granted, fewer shifts, but I continued to work clinically. But then it became an issue where the folks in the staff I was working with on shift couldn't separate my CMO responsibilities or leadership responsibilities from my clinical responsibilities. So it was very difficult to try to, no, I'm taking care of an acute group of patients right now. I can't address medical records issues or, delays in scheduling or something like that, just making it up. So actually, after the first 2 to 3 years, I actually stepped away from the clinical. I love the clinical, absolutely love the clinical, but I stepped away from that at the time so I could focus more and grew because there was so much to do on the administrative executive leadership side.
Yeah, I'm familiar with that. It was interesting. I really tried hard and have been fortunate to be able to maintain a clinical presence in various leadership roles. But when I was a senior vice president at one point, we had 360 feedback from all of our direct reports. And I remember distinctly one of them said, what can Dr. Moores do differently? And it said, stop doing neurosurgery. So
Yeah,
that tension is there, right? The
yeah,
people that
yeah,
you're working with in those roles want a piece of you
yeah,
every
yeah.
day
And,
and to
and
be responsive. And it's hard to balance those.
sorry to step on you, but
No.
ethically and intrinsically, it's a very hard push and pull because if you're taking away from one, you you know, may be able to give more in the moment to whichever it is. And it's interesting. I'm actually coming full circle to, you know what, it may be time to go. I'm interested in potentially going back into some bits and pieces of clinical. work at this time. Just, again, I'm a full circle connect the dots person. So I think it'd be, interesting at this point.
Well, it's always interesting. I felt too in leadership roles that I've been in that having contact with what's going on in the front lines, real contact, can be beneficial, not just because people talk to you differently when you're in scrubs in the OR
Yeah.
versus in a suit walking around with a bunch of other suits.
Yeah.
And I think you also have some credibility because you're struggling with the same EMR they're struggling with. You're trying to finish your notes. You're trying to, submit your billing codes with many, many, many new codes coming up all the time, et cetera, et cetera. So
Yeah, it's interesting you bring that up. And I think that credibility piece, because I think when we first started, let's say I'm dating myself again, but first started in physician leadership, it was almost that you had to have that active clinical right now piece to add the credibility. And I totally get that. But I think throughout the years, there's been some recognition that, gosh, for instance, in my case, I practiced over 20 years in the emergency room. So it's almost like, okay, yeah, we know
you
you're,
get it.
and
Yes.
we know you get it.
Yeah.
So now it's more about, at times it's even a broader, wider lens into what can we change? What can we make different? And I love it that some in physician leadership now are actually bringing expertise from other industry, whether it's, manufacturing or whether it's technology. Or I think the more we infuse that physician clinician perspective into that, it just makes it that much stronger.
Yeah. And there's a lens that I don't think you ever lose. If you've practiced medicine for X number of years, then when you're in the boardroom or you're dealing with industry, then that stays with you. That what does this do for the patient core?
Yeah. Yeah. There's no question. It's at the heart of what you're doing. If you're not keeping that relationship with the patient front and center, you just lose a lot of ground, lose a lot of momentum. And I've seen, unfortunately, we've all done it. We've seen people lose sight of that, or it kind of triage their priorities a little differently. So you're able to bring that back home.
That's awesome. Let's talk a little bit about CAI, which, as you point out well, is not AI, right? It's clinical augmented intelligence, because AI is everywhere and
Yeah.
CAI is not exactly AI. I won't steal your thunder on that, but tell us a little bit about where that is, where you see it going, how real time is it versus beta testing? Where is this being implemented and how's it impacting patient care?
Yeah, it's very difficult to keep on the veracity and the pace that it's come. Everybody doesn't define AI in the same way, so you have to be very careful with that. But I really think, and again, this is my perspective and some of the teams that I've worked with, the possibility, and I know the possibility is there for clinically augmented intelligence. And that's in the sense of not only we know now with mammography reading, we know now with some retinal scan reading, we know now with some data that the diagnostic utility is there. I don't want decision making to come to me from AI. I want support in my decision making with my relationship with the patient. Keeping the human in the loop perspective is where I come from on this. And it's not that it needs to be more of a supportive in nature, as in, okay, what records do I need to look at? It should automatically know if I'm seeing a chest pain patient in the ER, records pertinent to that type of presentation should be right there for me. Okay. Now I know I'm talking years out, but and it depends on the interoperability, it depends on the functionality, it depends on, but the ability to not only be diagnostic in nature, but supportive in the therapeutic sense. I should be able to, again, I use the example of chest pain. I should be able to see, okay, these are your options for a platelet inhibitor, or given these medications, boy, you need to watch out for this. And I'm not talking about the standard alerts that a lot of the EHRs have done a great job on. We have the standard if I'm going to order cephalosporin, hey, alert, there's an allergy to penicillin. Okay, I already know that. That's not useful and supportive to me. So that's that next layer of where I think we can really get to. But it takes a lot of foundational access to what we need in those types of evidence-based protocols and evidence-based care.
Yeah, I relate this to restoring your joy in medicine a little bit.
Of
All
course.
of us struggle with the amount of time that we have to spend looking at a computer screen to do our jobs, and whether it's live recordings that then dictate the interaction into a soap
Okay.
note, or as you're
Mhm.
describing, something that can comb through what are just increasingly voluminous records across multiple systems into a distilled version that saves you time and allows you to focus on the patient. I can keep my eyes on the patient because something's doing that search for me. Who's doing this well? If our
Boy,
listeners were to
that's
say,
a tough question. I can't
where do we go? I mean, give me
yeah.
this, right? I want
There's
this.
just I can't pick out one person to say, "Oh my gosh, these folks." I have seen some systems that are utilizing data in a really good, strong, supportive way. I haven't seen the system that is comprehensively pulling what I need for that focused patient for what they're presenting with. I'll be honest, I have not seen that yet. I know there are several folks working on it, and when you think about it from a risk management standpoint, what you were talking about, the volumes of data and the volumes of information, and I mean, I can harken back to being in the ER and, I've got somebody presenting with, let's just say, belly pain, a 72-year-old with belly pain. And then you start looking in the record in the EMR and, you've done your initial assessment, you're working them up, and you start seeing, oh my gosh, they've had, 30 visits in the last 5 years. So from a risk management quality standpoint, efficiency standpoint, deliverable standpoint, we've got to get there where that access is that much simpler. But again, supportive, not determining in nature, but supportive in what you're trying to do for your patient and how they present.
Yeah, and to your point, those 30 visits are the ones that you can see in your EMR at that
Right,
time, right?
right,
Not 6 other systems in 4
right.
different states that aren't communicating regardless of our attempts to do so.
And by the way, I had a CT when I was on vacation and, XYZ. And it's interesting. I think part of my interest in this, honestly, when I think back, is I was on the initial HIE in Illinois. I was on their board, and how we actually got information, how we were actually trying to share, and we had competitors at the table, hospital system competitors saying, Listen, we've got to get to this." But it wasn't near at the level of where I think we could be now with, the introduction of I'll put it in air quotes, AI, um, and how we can get there.
Yeah, so you brought that up, that was actually my next question. In the bigger scale, beyond the augmented intelligence AI, but the AI that we all kind of think about that's actually generative, using that in healthcare, just generally speaking, a clinician gets a report from some Gen AI. How does that play into the quality safety work that you're doing? How do I know how valid something like that is? I mean, when a medical student or a resident tells me something, I have some ability to judge, and I can ask them where they got that sodium result from. But where do we go in the AI future?
Yeah, I think we have to be very, very careful and astute and have really wide eyes wide open on the governance and the structure. If we don't understand what question we're actually asking AI to help us with, there's just we have to be very careful with it. And then end user, we all know of different systems that are out there with only certain users can get to certain parts of a system, et cetera, et cetera. But the governance in there and, I mean, frankly, clinician, medical staff approval, because I really think at its core, AI can look very different depending on what institution you're in. Can look very, very different. Certain rights, responsibilities, application, who can see from the very beginning, who can see results of an AI generated query, that's key in and of itself.
Yeah, and what can the AI see, right?
Right.
What are the boundaries that we put on their ability to generate things? Is it all internal? Do they have some external access?
Right.
And then, where does that feed directly? I talk about privacy
Right. Right. Oh,
concerns.
the privacy and security. And then if you're coming from the other end, I see from a population health perspective, and I'm sure you thought of this, Leon, from a population health perspective, what we could do with community. Let's just start with the community generated. Okay, what's the level, or what's the depth, or what's the impact of, let's say, top 5 chronic diseases right now, and how can we address that? I think that opportunity is massive, massive, and it doesn't have to be. It can be de-identified. It can be de-identified data. I don't have to know my neighbor's top 5 diagnoses. I can see from a global perspective. Okay, what resources would really make sense in this setting, in this community, to just make that delivery that much more efficient for the community, and better health outcomes overall.
Yeah, and you bring a great perspective as an emergency medicine physician, that the users of some of the most intense, high-cost interactions that we have, if you prevent those, not only are people healthier, but we have more resources to take care of the folks that are really super sick, right? That's great.
Yeah, I mean, and think about everybody's seen this. When you think about the aging population, the multiplicity of chronic diseases, the polypharmacy involved, it's just getting that much more complex in how and when to address the various, and this isn't even getting into prevention, right?
Yeah.
This isn't even, touching that.
Yeah. Why did you look very closely at me when you said aging population? I just wanted to.
Oh, no, I thought you
What
were
about
looking
that?
at me. I thought you were looking at
Stop.
me.
Stop it. Stop it.
No, I tell
Oh.
everybody I'm 24 and I'm gonna stick by it, so.
Yeah, I'm waiting for AI to eventually generate George Clooney's face on mine, but that, I suppose, will have to wait. What won't wait, though, is the second part of our conversation. Coming up next on All Physicians Lead, Dr. Maria Granzotti will share insights on how we can balance the needs of our patients with the demands of running a business.
I've always felt that when you do the right thing for the patient, it's gonna add value itself, right? When you focus on the safety, when you focus on the quality, when you focus on the appropriateness of care, align those with your core responsibilities and core capabilities, it's gonna take care of itself.
This has been All Physicians Lead. We can all be better leaders, and our teammates and patients will be the beneficiaries. Go to allphysicianslead.com to unlock your potential, sharpen your impact, and elevate your journey. All Physicians Lead with Dr. Leon Morse is a production of Forbes Books.